Miscellaneous idiopathic chorioretinopathies. The conditions described, which we will describe, are uncommon inflammatory disorders principally involving the posterior segment. Their etiology is unknown or incompletely understood. Other entities may present with similar clinical manifestations. It is critical to exclude alternative diagnoses including infection and neoplasia. The white dot syndromes constitute a subgroup with some features in common. There is variation between sources in the list of conditions falling into the category of white dot syndromes. The white dot syndromes consist of multiple evanescent white dot syndrome, acute posterior multifocal placoid pigment epitheliopathy, birdshot chorioretinopathy, punctate inner choroidopathy, serpiginous choroidopathy, multifocal choroiditis, and pain uveitis. And last is subretinal fibrosis and uveitis. First one is multiple evanescent white dot syndrome. MUTS is an uncommon idiopathic disease of acute onset, typically occurring in young adult females, with 25 to 50% describing a preceding viral-like illness. Commonly present with painless monocular blurring between 6:9 and 6:60 vision. Photopsia. Less common symptoms are floaters, scotomata, dyschromatopsia, subtle posterior vitritis in 50%, posterior pole lesions, numerous small, about 100 to 300 micrometer, ill-defined, deep gray-white patches, as shown in this picture. Numerous macular patches sparing the fovea, which has a characteristic orange granular appearance and a dull reflex. So these are deep gray-white patches. Optic disc edema is occasionally present. Recovery occurs over weeks, often leaving a subtle residual signs. Recurrence occasionally occurs in 10% cases. Investigations. Visual fields. The blind spot is commonly enlarged with a temporal field defect. OCT may show inner segment, outer segment junction disruption, and dome-shaped outer retinal lesions. FA shows subtle early hyperfluorescence of the dots with late staining, as shown in these pictures. Vessel wall leakage and disc staining may be seen. ICGA shows hypofluorescent spots that are often more numerous than visible clinically are on the FA. This is the FA of the previous picture, which shows hyperfluorescent spots. It says ICGA showing hypofluorescent spots. Visual field blind spot is commonly enlarged. OCT inner segment outer segment junction disruption. ERG shows transiently reduced AVO amplitude. Electrooculography EOG and visual evoked response abnormalities may be present. Treatment is generally not required. Symptom signs start to improve spontaneously by 2 to 6 weeks in most cases. In rare cases, treatment is needed for choroidal neovascularization. Another disease is acute idiopathic blind spot enlargement syndrome, rare condition, reported in young to middle-aged women. There is photopsia, decreased vision, blind spot enlargement, mild disc swelling, recovery to normal or near normal without treatment is usual. Some authorities believe that this is not distinct from multiple evanescent white dot syndrome. Acute posterior multifocal placoid pigment epitheliopathy, uncommon bilateral idiopathic inflammatory disorder, affect young to middle-aged adults of both genders equally. There is a viral prodrome in one-third speculated to occur as a result of cell-mediated immunity to viral antigen. The exact pathogenesis is not known. It has been suggested that inflammation at the level of choriocapillaries result in hypoperfusion and ischemia of the RPE and photoreceptors. Associated cerebral vasculitis can occur, but is uncommon and can cause stroke, erythema nodosum. Other systemic manifestations of vasculitis have reported. Clinical picture of this can be mimicked by other entities such as sarcoidosis and tuberculosis. There is subacute moderate visual impairment with central paracentral scotomata and photopsia. The fellow eye is affected within a few days or weeks. Headaches and other neurological symptoms are common and can commence many months after ocular disease onset. Anterior uveitis and vitritis are usually very mild. Fundus, multiple large, deep yellow-white placoid lesions. Multiple large, deep yellow-white placoid lesions initially at the posterior pole. Within weeks, the majority fade with residual RPE disturbance of varying severity. Subretinal macular fluid may be seen. Vasculitis and papillitis are rare. Prognosis. The visual symptoms and retinal appearance typically improve within weeks. In the long-term prognosis for most patients is good. However, there appears to be a subgroup of patients whose symptoms may recur and who have a longer period of disease activity. In 25%, visual recovery is limited to 6 by 15 or worse as a consequence of RPE and photoreceptor damage to the fovea. Investigation alternative diagnosis should be excluded. HLA-B7, HLA-DR2 are associated in a substantial proportion of patients. OCT of the macula is done. FAF active lesion shows early dense hypofluorescence and late staining. ICGA demonstrate non-perfusion of the choriocapillaries. CNS imaging and lumbar puncture should be performed in patients with neurological symptoms. Treatment not usually required. Steroid should be considered for patients with macular involvement. Steroid and possibly cyclosporine may be given for cerebral vasculitis. Patients should be instructed to seek medical advice urgently if neurological symptoms occur. Serpiginous choroidopathy. Serpiginous choroidopathy or choroiditis is usually bilateral, though asymmetrical. Inflammation occurs in the outer retina and choriocapillaries. Typically occurs in middle age, affects men more frequently than women. Associated with HLA-B7. Disease is generally recurrent over years. Relatively poor prognosis. TB uveitis can give similar clinical picture. This is known as serpiginite in case of TB uveitis. So TB should be excluded. Clinical features. Initially unilateral blurring of central vision, scotoma, metamorphopsia, interior uveitis, vitritis are common, usually mild. Active lesions are grey, white, and may remain active for several months before becoming scalloped and atrophic. So the disease typically starts around the optic disc, extend gradually, is shown in this picture. Though a variant starting at the central macula is recognized, here is the early active disease and here is the active extension around the macula in a typical snake-like fashion. Recurrence is usually contiguous with or adjacent to existing areas, eventually resulting in extensive chorioretinal atrophy as shown in this picture. This is advanced scarring. Complications: CNV in 15 to 35%, subretinal fibrosis, preretinal neovascularization. TB should be excluded, especially in endemic areas. FA of active lesions shows early hypofluorescence and late hyperfluorescence. Early hypofluorescence and late hyperfluorescence. ICG of active lesion reveal marked hypofluorescence throughout all phases of the angiogram. Oral or intravenous steroid may control activity. A variety of immunosuppressives and infliximab may be effective alone or in combination. So oral or intravenous steroids. Another is relentless placoid chorioretinitis (RPC). This refers to a rare entity showing features of both APMPPE and serpiginous choroiditis, and also referred as empyginous choroiditis. And there is persistent placoid maculopathy (PPM), rare condition, features lesion similar to those of macular variant of serpiginous choroidopathy, but which generally behave in a more benign fashion unless complicated by CNV. CNV is common. So this is persistent placoid maculopathy. Acute macular neuroretinopathy (AMN) is a rare self-limiting condition. Typically affects healthy young adult females. May affect one or both eyes. May be preceded by flu-like illness. Symptoms consist of decreased vision, paracentral scotomata, red-brown wedge-shaped lesions are observed in a flower petal arrangement around the center of the macula corresponding to the scotomata. FA is normal, shows faint hypofluorescence. Symptom and sign fade slowly over months with visual recovery. And there is acute zonal occult outer retinopathy (AZOR). AZOR, the acute zonal outer retinopathies, are a group of rare conditions characterized by acute onset of loss of one or more zones of visual field, often temporal in one or both eyes of young or middle-aged females, some of whom have an antecedent antecedent viral-like illness. Photopsia in mild vitritis are frequent, and subtle vasculitis is sometimes seen. Mechanism is unknown. Acute zonal occult outer retinopathy is the most common of the Azor syndromes and is characterized by minimal fundoscopic signs early in the disease course. The other postulated members of the group have more evident findings. Field loss may progress and recovery is infrequent. Later finds include RPE, clumping, and vascular attenuation in the involved area and peripapillary region. So, RPE, clumping, and vascular attenuation. OCT, FA, ICG, FAF may demonstrate abnormalities. Here, FAF showing hyperpigmentation nasal to the disc. Note that abrupt transition between abnormal and normal retina. OCT image of this shows serous retinal detachment. ERG. ERG is important for diagnosis, characteristically showing A wave and B wave amplitude reduction. A wave and B wave amplitude reduction and delayed 30 Hz flicker because cones tend to be affected more than the rods. EOG shows absence or severe reduction in the light rise. Stabilization occurs within 6 months in up to 90% of patients. Final visual acuity is 6/12 in at least one eye in most cases. Recurrence is sometimes seen. There is no proven treatment, although rare, or there are reports of favorable outcomes from systemic steroids. In the rest, punctate inner choroidopathy typically affect young myopic women. Both eyes are frequently sequentially involved. Similarities with MCP, which we will discuss, but involvement predominantly involves the macula. It is sometimes categorized with MCP and possibly SFU, which we will discuss as pseudo POHS. So it has similarities with MCP. MCP means multifocal pain uveitis, multifocal choroiditis, and pain uveitis. There are these blurring floaters and photopsia. Acute anterior uveitis and vitritis are usually absent or very mild. Fundus, there are several small yellow-white macular spots with fuzzy borders at the level of inner choroid and retina, sometimes with an overlying serous sensory retinal detachment. These evolve into sharply demarcated atrophic scars with little pigmentation, similar to the histospots. Of presumed ocular histoplasmosis syndrome. That's why this is known as pseudo POHS or pseudo presumed ocular histoplasmosis syndrome. Prognosis: central vision may be compromised by a lesion at the fovea or commonly by CNV in about 40%. FA shows early hyperfluorescence and late staining of lesions and demonstrates CNV. This is FA arterial phase. Several hyperfluorescent spots with hypofluorescent edges inferior to the fovea, lacy hyperfluorescent at the fovea, indicating choroidal neovascularization. FA late phase, discrete hyperfluorescent spots, intense hyperfluorescence at the fovea. Anti-VEGF medication should be used for choroidal neovascular formation in the macular region. Steroid and systemic immunosuppressive therapy can be helpful in the management of recurrent CMV. Inner is idiopathic multifocal choroiditis. It is an uncommon, usually bilateral but asymmetrical chronic or recurrent disease typically affect young and middle-aged adult females. Severity and prognosis are very variable. The etiology is unknown and the condition is diagnosed clinically after systemic and infectious disease. So tuberculosis, West Nile virus choroiditis, candida has been excluded. Symptoms are blurring floaters, photopsia, anterior uveitis and 50% vitritis. On fundus, there are multiple discrete white yellow-gray lesions 50 to 300 micrometer at the posterior pole and are periphery, sometimes with linear clusters and are streaks. Inactive lesions have sharply defined margins and pigmented borders resembling POHS, presumed ocular histoplasmosis syndrome. Peripapillary atrophy may be seen. The course is prolonged with the development of new lesions and recurrent inflammation episodes. CNV occurs in 25 to 35%. CMO, subretinal fibrosis resembling SFU can develop, which we will discuss SFU. Optic disc edema and blind spot enlargement may be present. Investigations, visual field may show large defects not corresponding with examination finding. FAF, there is early hypofluorescence, late hyperfluorescence, or inactive lesions show window defects. If a neovascular membrane develops in the macular region, hyperfluorescence is seen due to leakage. So this is late venous space fluorescein angiogram showing hyperfluorescence at the fovea due to leakage from neovascularization at the macula. So ICGA shows hypofluorescent acute lesions which may not be clinically apparent. ERG remain normal until there is advanced retinal atrophy. Treatment is systemic and local steroids. Steroid-resistant patients require immunosuppressive therapy. CNV is treated with steroids and anti-VEGF agents. Progressive subretinal fibrosis and uveitis syndrome (SFU). Subretinal fibrosis and uveitis (SFU), also known as diffuse subretinal fibrosis. Extremely rare chronic condition. Affects myopic young women. Gradual blurring of vision in one then both eyes. Anterior uveitis vitritis accompanies subretinal mounds at the posterior pole and mid-periphery, progressing to widespread subretinal fibrosis and advanced disease. Steroid may be effective early in the disease, but the prognosis is poor. Some experts view SFU as a part of spectrum with MFC, MCP, and PIC. Multifocal choroiditis and pain uveitis and punctate inner choroidopathy. So this is a part. Some experts view this disease as a part of punctate inner choroidopathy or multifocal choroiditis and pain uveitis. Birdshot retinochoroiditis. Birdshot retinochoroiditis is an uncommon idiopathic inflammatory disease affect middle-aged women. Chronic bilateral, manifest with severe retinitis, stromal choroiditis, independent inflammatory events. There are independent inflammatory events. All patients are HLA-A29 positive. Patient present with insidious impairment of central vision with photopsia, floaters, Vitritis is present in either one or both eye. In fundus, there are multiple ill-defined, wide, cream color choroidal patches less than 1 disc diameter in size in the posterior pole and mid-periphery. The lesions often appear to radiate outward from the disc but usually spare the macula itself. Inactive lesions consist of well delineated atrophic spots. These are inactive lesions. CMO, epiretinal membrane, CNV may develop visual field testing, not visual acuity. Visual field testing is the appropriate functional test for monitoring disease evolution and response to treatment. About 1/3 of patients have an eventual best visual acuity of less than 6/60. However, results are starting to improve with aggressive and sustained immunomodulatory treatment. Choroiditis respond well to this treatment, but the retina less so. HLA-A21 in 95% of patients are positive. OCT will confirm macular edema. Autofluorescence will generally show more numerous hypoautofluorescent lesions than are seen on examination. If it shows extensive vascular leakage, it can show diffuse macular edema. This is the late phase. If it is showing disc vessel leakage, vessel wall staining. Vessel wall staining. This is early phase ICG showing numerous hypofluorescent lesions. Fovea is often spared here. In the true cystaid macular edema is less common. ERG is normal in early disease. With time shows rod and cone abnormalities. HLA-A29 histocompatibility antigen is present in almost 100% of patients with birdshot retinochoroiditis when PCR methodology is used. The first tip is to use subtenon triamcinolone acetonide 40 mg, particularly in patients with monocular disease. Up to 90% of patients need systemic treatment. Early referral to a uveitis specialist should be considered. Systemic steroids are used initially, but immunomodulatory treatment is often needed, usually mycophenolate followed by infliximab. In their disease is unilateral acute idiopathic maculopathy. Acute idiopathic maculopathy is a rare self-limited condition, most frequently unilateral, may be preceded by flu-like illness. Patients are young adults who describe sudden marked reduction in central vision. Viral prodrome is common, associated with systemic infections have been noted. Irregularly yellow or gray exudative retinal detachment is seen at the macula, associated with small hemorrhages and papillitis. Within a few weeks, exudative changes resolve. A bull-eye appearance may develop following resolution. So, as shown in this picture, macular appearance after a further month can be associated with persistent visual loss. OCT shows hyperreflectivity at the photoreceptor outer segment layer, RPE thickening. FAF shows triple hyperautofluorescence that become hypofluorescent. FA shows early irregular mild hyperfluorescence at the detachment with subsequent intense staining. So as shown in the picture, hyperfluorescence of subretinal fluid. Treatment is not given. Next is acute multifocal retinitis. is a very rare SIP-limited condition, may be preceded by flu-like illness, possibly an atypical presentation of Gates-Krich disease. It causes sudden onset of mild visual loss in young adults. Multiple areas of retinitis are seen posterior to the equator along with mild vitritis, disc edema, and sometimes macular star. Recovery occurs over 2 to 4 months. Treatment as for Gates-Krich disease may be considered. Frosted branch angiitis FBA. Characteristic fundus picture bilateral may represent specific entity primarily or a common pathway in response to multiple stimuli. Secondary FBA may be associated with infectious retinitis, notably cytomegalovirus retinitis. Other conditions such as lymphoma and leukemia, here in this case is lymphoma. Primary idiopathic FBA is rare, typically affects children, young adults. Presentation is bilateral visual loss, 6:30 to perception of light, floaters, arpotopsia, and arpotopsia. Maybe a viral prodrome, florid sheeting of retinal arterioles and venules is seen. Florid sheeting. Anterior uveitis, vitritis, retinal edema are common. Treatment is with systemic steroids, though some authorities believe the prognosis, which is usually good in the primary form, is unaffected. This is idiopathic retinal vasculitis, aneurysm, and neuroretinitis syndrome, Irwin syndrome. Idiopathic retinal vasculitis, aneurysm, neuroretinitis syndrome is a rare entity, affects one or both eyes of healthy young women. Fundus sign consists of arthritis and multiple aneurysmal dilatations of arteriolar branches and optic nerve head together with anterior uveitis, vitritis. Disc edema, macular star, also known as neuroretinitis, are common. Marked macular and circumpapillary exudative retinopathy can develop this sarcinate pattern of hard exudates surrounding the disc. There is also venous irregularity, obscuration of the optic nerve head. Muscular changes are demonstrated well on the FA. Extensive peripheral capillary non-perfusion may lead to preretinal neovascularization. Early pain retinal photocoagulation should be considered. Intravitreal anti-VEGF treatment steroids have been associated with good result in some patients, may give in combination. This is FA showing multiple aneurysm at AV bifurcation and marked variation in arteriolar caliber.